For the last part, we're going to move quickly through a couple of trials of interest. I think Tom may have mentioned this trial a little bit earlier, but the AVANOVA trial was an open-label, randomized phase 2 in recurrent platinum-sensitive high-grade serous or endometrial cancer, and it was designed to evaluate the combination of niraparib and bevacizumab versus niraparib alone, and this was as an alternative to cytotoxic chemotherapy. So the combination showed a significant improvement in progression-free survival, and this was both in the intent-to-treat population at 11.9 versus 5.5 months, and a number of pre-specified exploratory analyses as well, including in a stratified by chemotherapy-free interval, be it 6 to 12 months and greater than 12 months. And you can see the difference in PFS in those groups. And we also saw a PFS difference in the exploratory analysis stratified by BRCA mutated versus BRCA wild type, as well as in the HRD negative or HRD positive versus HRD negative, or I guess we say HRP versus HRD now. We're all learning to change or unify our lingo when it comes to that, certainly. And then the overall response rate with the combination was 60 versus 27%, and the disease control rate was 79 versus 53%. And then the last trial we'll look at of our trials of interest is the randomized phase 2 BAROCCO trial. Certainly, I give this one the nod for the best acronym. It's the best approach to recurrent ovarian cancer with cediranib olaparib, or BAROCCO. And the trial evaluated a continuous versus intermittent dosing regimen of cediranib olaparib in platinum-resistant ovarian cancer. So 89% of the patients in this trial were BRCA wild type or unknown. A little over half of them had seen previous anti-angiogenic treatment. And again, a little over half of them had 3 or more lines of chemotherapy. The primary endpoint was investigator-assessed PFS, and this was 3.1, 5.7 and 3.8 months respectively between the Taxol, the continuous dosing of cediranib, and the intermittent dosing of cediranib. It's interesting, the hazard ratios for PFS with continuous and intermittent therapy were 0.76 and 1.08 respectively. But for the continuous regimen, the comparison was not proportional. The difference of the area under the curve for the PFS actually came out to a 1.25 months in favor of the continuous therapy with olaparib cediranib combination. So a lot to unbundle there on that slide and in this study as well. So we await to see more data coming from this. Again, this forest plot just shows some of the subgroup analyses with a greater benefit with continuous combination therapy in BRCA wild type or unknown, and a similar trend was seen in patients who had received up to 2 prior lines of therapy and those with no previous anti-angiogenic treatment. And this KM curve demonstrates the PFS in the BRCA wild type cohort, or BRCA wild type or unknown combination, with PFS of 2.1, 5.8, and 3.8 months in the paclitaxel continuous versus intermittent groups, respectively, demonstrating again that aforementioned trend favoring continuous, and an AUC showing a difference of 1.82 months survival. And so the hope was in this combination that the intermittent schedule, if equivalent, might improve the GI tolerability, as this treatment had been associated with a pretty significant amount of GI toxicity and diarrhea in past trials. However, really the toxicity profile of the study arms was pretty much as expected and similar between the experimental arms, with 11, 18, and 7%, I believe it was, discontinuing for adverse events. So I guess that there certainly are a lot more trials of interest out there, but for the sake of time, I think we'll draw it to a close there and turn it back over to you, Shannon.
Yeah. Thank you so much, Chad. That was great. And really thank you both for such a thoughtful discussion. These were great cases. And really, I think we got through so many topics in a short period of time. And I'm thankful to both of you for being here with me. And to our viewing audience, I want to thank you for joining us for this Targeted Oncology Virtual Tumor Board presentation. We hope today's discussion was a valuable use of your time and that you acquired some practical knowledge that you can take back to your clinic. And again, thank you all for joining, and please take care.